Hello, everybody. Welcome to the 2026 Stroke Education. I know you've all been waiting for this education. You've been hearing about it. Here it is. My name is John Toit. I am the Director of EMS Operations for the Oakland County Medical Control Authority.
Hello, this is Bonnie Kincaid, the Executive Director of the Oakland County Medical Control Authority.
And hi there, it's Gedalia Cooper, Deputy Medical Director at OCMCA.
Hello, everybody. This is Kevin Snell. I'm the EMS Coordinator for Oxford Fire.
So this stroke initiative actually began 10 years ago. We started going down this path, training providers how to do a FAST-DD score, and then doing a correlation between that and the NIHS score at the hospital. And it's been 10 years in the making to get to this point where we are today. So we chose to use FAST-DD based on a lot of neurologists and stroke coordinators at the time that were looking at the research and the different severity scores. So FAST-DD was chosen as the best severity score to use in an EMS setting. The state of Michigan then did a study looking at how FAST-DD compares to the NIH, how they score a stroke in the hospital. And the Spearman's RHO correlation to the NIHSS is really amazing. It's a 0.687, which is a great score. That means there's a strong correlation between the two scores. Also, the state came out with 84% of FAST-DD scores of 4 or greater equate to an NIHSS score of 6 to 42. So that means they're both looking at severe strokes.
It turns out that the OCMCA actually was way ahead of our time because in 2026, there was a study that came out on new ischemic stroke guidelines in the journal Stroke. It said a lot of different things in regards to hospitals and pre-hospital. But the thing that really is going to matter for us is that the evidence shows that patients should be directly transported to the closest endovascular thrombectomy capable hospital if they are felt to have an LVO.
So we've been preparing for this for a little while. One of the things that we've really started to look at recently with the Michigan Stroke Program is a way to improve the EMS data. Because if we can improve the EMS data, we can make data-driven decisions. And that is our goal. We want to make data-driven decisions that improve patient care for the patients and also reflect what the providers are doing in the field. And in order to do so, we started looking at some specific data points. And we had a stroke town hall. During the review of the data points and the stroke town hall, we've determined some educational needs for this stroke protocol that's coming out on September 1st. And the goal of the CQI initiative from the beginning was to improve patient care and improve stroke documentation data so that we can overall improve stroke performance in the OCMCA.
So we appreciate everybody's patience with the Stroke CQI initiative and the education that we've been learning over the last few months. We will be implementing this protocol on September 1st, 2026 here in the Oakland County Medical Control Authority. The state of Michigan has approved our stroke protocol and our transportation protocol. So the major change here is going to be any patient with a FAST-ED of 4 or greater will be transported to a level 1 or level 2 stroke hospital. This stroke and transport protocol education has been created for all the EMS providers to review protocol and answer some questions that have arisen since the stroke town hall meeting. All the EMS providers will have to view this education prior to September 1st, 2026, when the protocol will be implemented.
The OCMCA will be continuing to work with the Michigan Stroke Program to improve data throughout this process. And after September 1st, we will also be looking at the FAST-DD scores and continuing to look at comparisons to the NIHSS score. The protocol we are looking at is Protocol 3.2, stroke or suspected stroke.
So as with every protocol, we're going to start following 1-1, the general pre-hospital care protocol. If we suspect a stroke, we should obtain a Cincinnati pre-hospital stroke scale, just as we used to in the past. The main difference between this new protocol and the old protocol is the box at the bottom. where it says if all stroke signs and symptoms are absent, we went to the next protocol. So most providers looking at the current protocol feel that once the Cincinnati stroke scale is negative, there is no sign of a stroke and they were done with the stroke assessment. But what we're trying to get the providers to understand at this point is that there are other signs and symptoms of strokes that are not caught with the Cincinnati pre-hospital stroke scale. And those are the ones that we need to make sure we're highlighting to the hospitals in our stroke alerts.
Dr. Cooper, one of the things that I found doing the stroke CQI, we had some patients that have a history of stroke deficits, but they aren't worse that day. Do they have to do a fast ED score just due to their history?
That's really difficult question to answer because it really depends on the symptoms that the patient is having. If the patient has a previous stroke and has chronic deficits and you're getting a history on scene that everything is exactly the same, then I guess the important thing to figure out would be, why did they call EMS? In a situation where you're going to worry about a stroke, they're going to have called EMS because something changed or something was worse.
So if we're looking at bullet point number 2, stroke screen, if the patient presents with a new onset neurologic complaint. Dr. Cooper, we've been getting a lot of questions from providers regarding this. Is there a specific time frame from symptom onset that a stroke alert is not necessary?
The study that was published in the journal Stroke in 2026 does mention multiple times about 24 hours of symptoms. We'll probably talk about this more at some point during this discussion, but one thing that's very important is to talk about the terms symptom onset and last known normal. Patients a lot of times will use the terminology, these symptoms all started when, and that's not necessarily the last time that they were known normal. For example, if a patient wakes up at 9 o'clock in the morning and they can't move the left side of their body, that is when they notice the symptoms, and that's what they would call symptom onset. But the last known normal may have been when they went to bed 12 hours before that. So that is something that is very, very important to tease out.
So for the purpose of the 24 hours, are we discussing from symptom onset or from last known normal?
So the 24 hours is really from last known normal, because that's what we base all of the treatment decisions on. Sometimes symptom onset and last known normal are the same thing. But in the example I just used before, where it was a wake-up stroke, or the patient can't speak and can't tell us when the symptoms started and family last saw them 6 hours ago at lunch, let's say, then those two things diverge and they're different.
So if we have a patient that last known normal was greater than 24 hours, should we continue down the stroke protocol?
So absolutely continue down the stroke protocol. The question would become, are they going to be a candidate for intervention even if they do have a large vessel occlusion? With the way the protocol is written, time shouldn't be a factor.
Okay, Dr. Cooper. So down in the gray box here, if the CPSS is negative and all stroke signs or symptoms such as visual changes, single limb weakness, confused speech or absence, we're moving on to the next protocol. What if one of them exists, such as dizziness, visual changes, or a single limb weakness?
So if one of those things exists, then we continue down the stroke pathway and the stroke protocol, because those things can still be consistent with stroke. You know, all of these pre-hospital scores and also are really based on the ones that we use in the hospital. And the one that we use in the hospital is also terrible at picking up some of these posterior strokes that present with dizziness or visual changes or feelings of off balance. But those are still strokes just as much as what we classically think as a stroke, which is, like, let's say, where they can't move one side of their body. So in those situations, even though the Cincinnati stroke scale would be negative, we would still continue down this stroke protocol if there's any of those other symptoms that could be consistent with stroke.
That's a great point you make, because I get that question a lot from my providers and providers from other departments. So if the Cincinnati scale is negative, but there are other symptoms that could be a stroke, such as the dizziness, visual changes, and weakness, we will continue down this new protocol.
That is correct. And, you know, whether the fast ED score is going to be really high or really low, chances are with some of these other symptoms, you're not going to reflected on the fast ED score either. You're still going to go down the stroke pathway and do a stroke alert and all of those other things.
So the other question there, you bring up the fast ED. So even if there's a negative Cincinnati, but we have dizziness, visual changes, or single limb weakness, we're still completing a fast ED.
That is correct. And I mean, the thing to remember with this is, just because you get a fast ED score of 0, let's say, it still could be a stroke. A fast ED score is really a screening tool. It is not a diagnostic instrument. So you can't diagnose a stroke with a fast ED score. It's just helping you screen the patient appropriately.
So the other question I'm getting from my providers is, why don't we just do a Cincinnati stroke scale and a fast ED on everyone?
Fast ED score is not a diagnostic instrument, it's a screening tool. So the reality is just because a Cincinnati stroke scale is negative, if you're still worried about stroke because of whatever symptoms there are, dizziness or visual changes or confused speech that don't show up in the Cincinnati stroke scale, then you continue down the pathway and do your fast ED score. Some of this is going to be you thinking this could be a stroke, because if there's no other stroke symptoms, then you wouldn't continue down this pathway.
So what you're saying is we really shouldn't be doing a fast ED on every patient. It doesn't rule out stroke. It's a tool for patients that have possible signs and symptoms of stroke.
That is correct in a situation where your Cincinnati stroke scale could even still be negative. There are other symptoms that could be present that would lead you down this pathway.
Okay, Dr. Cooper, another question I've received from my providers. What if we encounter a patient who has speech changes and appears to be under the influence of alcohol?
There's going to be a lot of situations that come up where there could be multiple things happening. Is it possible that a patient is under the influence of alcohol and also having a stroke? Sure. But most of these patients that are under the influence of some substance, likely their speech changes are related to the substance. But as you're going down this pathway, if you're suspecting a stroke, so you're going to do your Cincinnati pre-hospital stroke screen, and you're going to do your fast ED. And if the only deficit that the patient has is a speech change, then really nothing's going to change. You're still going to transport this patient to the hospital. And if you're thinking this could be a stroke, along with the substances that the patient has ingested, then you call a stroke alert.
Okay, so another question that I've received from providers looking at the gray list. Is this signs and symptoms list fully inclusive here? Because I've had a lot of questions about why isn't dizziness included in here?
Great question. And the answer is no, that is not an all-inclusive list. Those are examples. So EG always means for example, but not all-inclusive. If we used IE in that protocol, then we would have to put everyone down that could possibly be on that list.
So this next portion of the protocol gets into talking about the times that Dr. Cooper covered earlier, the last known well and signs and symptoms of stroke were first discovered. Talks about calculating a fast ED score. So if you had a positive CPS or other signs and symptoms of stroke, you're going to go to time, you're going to look for last known well, you're going to look for signs and symptoms of stroke were first discovered, and you're going to calculate a fast ED score. Again, it is a stroke severity scale, not a tool to rule out stroke. And then you'll take a look at the stroke mimics.
And I just want to reiterate again, number 3 of this protocol, time, documented date and time. The absolute most important thing, arguably for us in the emergency department, is A, in this protocol, the time that the patient was last known well. That is very, very different sometimes than B, which is when the signs and symptoms of stroke were first discovered. A lot of times we have providers coming in, and patients and families also, when you ask the question, when did the symptoms start? And they tell you it started 10 minutes ago, you have to really follow that up with, when is the last time we know that there were no symptoms? Because those two answers can be very, very different.
All right, Dr. Cooper, another couple of questions we received is about how do we complete a fast ED on different patients? You know, patients that are unconscious, uncooperative, presenting with dementia, or have deficits from a previous stroke.
So these are all really, really difficult patient populations because there almost is never in these situations a black and white, like, oh, this is clearly a stroke or this is not clearly a stroke. So the first thing that really is you have to make that decision that I'm worried about a stroke in these patients and I'm going to go down this stroke pathway. When you talk about patients who are unconscious or uncooperative, there are still things on the FAST ED scale that you can score. And partial scoring can still be pretty informative, especially if your partial score is greater than or equal to 4. For example, an unconscious patient, you can watch if they have an asymmetric facial grimace, if you push on their nail bed, if they grimace and only the left side of their face moves. Or an uncooperative patient, you can just observe their facial movements. Even if they're not cooperating with you, it's usually pretty clear that a patient has a facial droop or one side of their face is paralyzed. You can do a lot of things from an observational perspective that can help you score these patients. As far as a patient with previous stroke, with deficits, obviously things like if their previous stroke left them with deficits on their right side and now they're having deficits on their left side, that is a problem. But I would say that when you're in doubt, just treat the symptoms as that they're acute. Things like gaze deviation, if their eyes are deviated to one side, that is very, very uncommon to be a chronic finding. So a lot of these things are really going to be the same idea, whether unconscious, uncooperative, also patients with dementia, things that you can tell by just observation, and they don't have to necessarily cooperate with you, are going to be very telling and may get you to that threshold of a FAST ED score of greater than or equal to 4. Otherwise, it really is difficult to tease out for the full FAST ED score in some of these patient populations.
Dr. Cooper, if you only have a partial score and it's less than 4, would you divert to a level 1 and 2 stroke center?
In a situation where you're only able to get a partial score when it's less than 4, I would not divert to a thrombectomy capable center because you do not reach that threshold of a score of 4 or greater.
So after calculating the FAST ED, we're going to look at stroke mimics. We need to identify what possible stroke mimics exist, including but not limited to hypoglycemia, Todd's paralysis following a seizure, drug and ETOH intoxication, migraines, and infections. Now, the next question for you, Dr. Cooper, what happens if a provider gets on scene, has a stroke mimic present, such as hypoglycemia, and the standard practice would be to obtain a blood sugar, start an IV, give some dextrose, and then recheck that blood sugar and determine if the patient is doing better. Once the blood sugar is normal, technically that was a stroke mimic that existed and was corrected. Is that to be treated the same as a TIA?
So those are not TIAs. So really, to just kind of boil it down, a TIA is just a stroke that got better in under 24 hours. So these situations, a Todd's paralysis after a seizure, or a hypoglycemic patient, or a patient who has a migraine, or a patient who has vertigo, but it's peripheral vertigo, or even a patient who has, a history of psychiatric illness. Some of these patients with psychiatric illnesses can sometimes mimic stroke. It's called conversion disorder. These are not actual strokes.
So, Dr. Cooper, if somebody has a patient that has a blood sugar of 40 and they correct the blood sugar to 110 and the stroke symptoms went away, do they have to continue down this protocol, or would they be going to a different protocol to continue treatment?
If the patient's symptoms completely resolve, then this would not be a stroke. So this would not be a time to follow the stroke protocol.
Well, that's a good explanation, Dr. Cooper. Thank you for explaining the hypoglycemia. After we obtain the stroke mimics and we determine that a mimic is present or not present, we're going to move on to sample history. We're going to determine if a blood thinner medication usage exists or not. We should document the name of the medication and the date and time of the last dose, and we should put that in our narrative. We should also check for stroke risk factors. Identify if the patient possesses predisposing stroke risk factors. So we want to keep the scene time to less than 15 minutes if possible. We do understand that EMS doesn't always have the ability to get somebody on the ambulance in less than 15 minutes. If that example exists, such as a hoarding house, patient is on the 5th floor, or maybe the patient is very large and takes multiple providers to move this patient, we want to document that in the narrative and justify why it took greater than 15 minutes to get the patient on the road. So unless the patient needs an immediate intervention, such as hypotension and would need an IV, we should limit obtaining IV access and obtaining a 12 lead to during the transport. If the stroke is suspected, we should position the patient supine on the cot to support collateral blood flow. We should also use O2 as minimum as necessary to maintain the SpO2 of greater than or equal to 94, just as our oxygen protocol requires. We need to make a transport decision using the 8.3 transportation protocol and the 8.31 OCMCA hospital transportation matrix. Patients with a FAST-ED score of 4 or greater need to be transported to a level 1 comprehensive center or a level 2 thrombectomy capable hospital.
So when we talk about documenting the name of the blood thinner medication and the date and the time of the patient's last dose, the reason that's really important in the emergency department is some of our treatment decisions as to whether we can give thrombolytics or not give thrombolytics really depend on what blood thinners the patient is taking and when they took their last dose. So this is a very important piece of information.
So another question we received, Dr. Cooper, is what happens when we encounter a patient with multiple complaints? Let's say they have some stroke symptoms present, but they're also complaining of chest pain. How do you want us to manage the 15-minute scene time and also try to treat the chest pain as well?
It would be very rare to have a stroke and a heart attack at the same time. There's a lot of things that can come to mind with someone who's having stroke-like symptoms and chest pain. But the thing to remember is you're taking these patients to a hospital either way. And you can be doing intervention en route. And it's important to minimize your scene time in general just to get them to a hospital. You can do a 12 lead on the way. And if you find that this patient's having a STEMI, you can make the appropriate decision at that time when you find that out. The same idea would be, stroke symptoms can also evolve over time. You could be on your way and all of a sudden the patient now is completely hemiparetic, can't move one whole side of their body. And now all of a sudden, this looks like an LVO. And you make these decisions about where you're going to go sometime in real time. So minimize the scene time. You can do your 12 lead on the way and treat the chest pain as well. But it's really going to be almost a clinical judgment of, are you going to work down the stroke pathway, or do you think that maybe this is really the chest pain pathway and it's an MI? But either way, it's important to remember that you're going to be getting this patient to a hospital.
So the next question we have would be, are all stroke patients, including negative Cincinnati, positive stroke signs and symptoms, or patients with stroke mimics present, are they all priority 1 transports?
It's really going to be based on provider judgment. But I do think if the provider judgment is this is an LVO and our FAST-ED is greater than or equal to 4, and we're going to bypass to a level 1 or level 2 facility, that should be priority 1. The bottom line is, at the end of the day, the 15 minutes, this is all just trying to get the patient to the hospital as quickly as possible, to get the intervention done as quickly as possible, to do what's right for the patient.
Stroke alerts. Number 8 in the protocol. This is what's included in the stroke alert. Provide a verbal or e-bridge stroke alert per the communications protocol to the receiving hospital as soon as possible if a patient has any stroke symptom that was or is currently present and or sudden onset of dizziness. All stroke alerts should include a FAST-ED score with a list of neurodeficits, last known well, date and time of symptom discovery, blood thinner usage, vital signs, any possible stroke mimic, estimated time of arrival, and it is recommended that if you have the ability on eBridge to do a video, to video your stroke assessment for the physicians to see at the hospital. Now in here, we've talked about already that stroke mimics you need to announce that you had a stroke mimic or you have a stroke mimic. That gives the hospital ability to make some decisions. It also says if the patient has any stroke symptom that was or is currently present. That means if the stroke symptoms have resolved, we still have to do a stroke alert, such as TIAs. And that would be if prior to your arrival, family says, hey, listen, they had a facial droop and right-sided weakness. You should still do a stroke alert.
So, Dr. Cooper, one of the questions I keep getting from providers is that, aren't we going to give the hospital too many stroke alerts? And how often are the doctors going to look at us and say, well, that's not really a stroke. Why are you calling it in as a stroke?
So the answer is, the TIA is a stroke. It's just a stroke that gets better. And we have to remember that stroke is not a static illness. Stroke symptoms can evolve over time. They can be dynamic. They can come and go. And so when you're calling in a stroke alert to a hospital, it's not necessarily, that this is a patient that's going to end up in the resuscitation bay, with lots of people around and the whole stroke thing. But it gives the hospital that information that, maybe if it's super busy and ambulance bay is really full, that this is somebody maybe they should check on a little more often, because even though it could have been a TIA and the symptoms could have resolved, they can always reoccur because these things are dynamic and they will evolve over time. It doesn't necessarily put the patient into a resuscitation room, but it gives the hospital the information that this is something that maybe we should be a little more on top of.
Dr. Cooper, while we're on the topic of TIAs, do we have to do a FAST-ED score for a TIA?
Strokes are dynamic and can evolve. And it's always good to have serial scores even potentially, so you can know what exactly is happening. So my thought would be, TIA is a stroke. It's just a stroke that gets better. So your FAST-ED score is going to be 0, but I would still do one.
That brings us to patient care report documentation. Here are some things that as providers you need to be thinking about. 1, you need to document the FAST-ED score and the deficits. 2, you need to document the last known well date and time. Date and time of sign and symptom discovery. Any blood thinner usage, you should document the name and the date last used. Next of kin information and a blood glucose level. These should be documented in the data fields. The other thing that needs to be documented is a FAST-ED score in the narrative. Now, this is not in the protocol, but we would appreciate that you did that. And the reason is because it is very difficult for the physicians at the hospital to find the FAST-ED score on the patient care records. In addition, when we're doing the study, data providers are only required to document a positive or negative score. So that means if it was a score of 1, it would be positive. A score of 0 would be negative. The problem is we really need to see whether there was a score of 4 or greater. So it would be very helpful for us if you put that into the narrative.
All right, to start with the FAST-ED review, we're looking for facial palsy. You want to ask the patient to show their teeth or smile. If both sides of the face move equally or not at all, that's a 0. If one side of the face droops or is clearly asymmetric, the score is a 1.
And that's whether it's a partial droop or a complete paralysis.
Then we're going to move into arm weakness. We're going to ask the patient to extend both arms, palm up in front of them, close their eyes, and hold there for a count of 10. The old providers in the field, we are no longer doing the arm strength test. We're doing arm drip, arms out, palms up. If both arms remain up for greater than 10 seconds or slowly move down equally, that score is a 0. If the patient can raise both arms, but one arm drifts down in less than 10 seconds, the score is a 1. If one or both arms fall rapidly, they cannot lift their arms, or there's no movement at all, the score is a 2. Then we're going to move into speech changes. We're looking for expressive aphasia. We want to ask the patient to name 3 common items, such as a pencil, a TV, or a chair. If they name 2 to 3 items correctly, that score is a 0. If they name 0 to 1 items correctly, the score is a 1. We're also looking for receptive aphasia. Ask the patient to perform a simple command. You can ask the patient to show me 2 fingers. If the patient is normal and follows the command, the score is a 0. If the patient is unable to follow the simple command, the score is a 1. The next part of the FAST-ED is eye deviation. If there is no eye deviation and the eyes move equally to both sides, that score is a 0. If the patient has clear difficulty when looking to one side, whether the left or the right, their score is a 1. If their eyes are deviated to one side and fixed and do not move to the other side, the score is a 2. We then move on to denial and neglect. We do not perform if expressive or receptive aphasia is present. Anosognosia is the medical term for denial. We're going to show the patient their affected arm and ask, do you feel weakness in this arm? If the patient recognizes the weakness in their weak arm, the score is a 0. If the patient does not recognize the weakness in their weak arm, the score is a 1. Asymmetric nausea is the medical term for neglect. This is where you show the patient their affected arm and ask, whose arm is this? If the patient recognizes their weak arm, the score is a 0. If the patient does not recognize their weak arm, the score is a 1. A FAST-ED score of at least 4 or higher indicates the likelihood of an LVO or a severe stroke.
There are so many scenarios that we can't cover in this education. We highly recommend that you come up with some unique scenarios, talk through them, and practice them at your agency.
That moves us on to the transportation protocol, Protocol 8.3. In this protocol, under number 4, stroke, it simply indicates that for a FAST-ED of 4 or greater, you need to transport the patient to a level 1 comprehensive or level 2 thrombectomy capable hospital. Bonnie, the stroke matrix is Protocol 8.3.1. What hospitals are thrombectomy capable or comprehensive?
As of June 2026, we have 4 hospitals that meet the criteria of either comprehensive or thrombectomy capable. In the center of the county, we have Corewell William Beaumont University Hospital. Over toward the west, we have Henry Ford West Bloomfield. Toward the south, we have Henry Ford Providence Novi. And then we also have toward the north, Trinity Oakland.
So those are the changes to the stroke protocol and the transportation protocol. If you have any questions, please feel free to contact us at bonnie@ocmca.org, john@ocmca.org, or amy@ocmca.org. Feel free to CC all of us on your questions, and we will get back to you as soon as we can. Thank you all for listening, and if you have any questions, please feel free to contact us.